to our Tuesday, May 18th virtual pediatric grand rounds. Today, Dr. Michelle Dalal will discuss from clinic to home, empowering school-age kids to be healthy, a lifestyle medicine-based approach. Before we begin, I do want to do a formal land acknowledgement to show appreciation for the past and present Indigenous stewardship of the lands we now occupy. We recognize that this virtual meeting is being hosted and recorded on the Dena'ina El Nena. Anchorage is the Dena'ina homeland. Thank you again, Dr. Dalal, for presenting today. Dr. Dalal is a pediatrician at Reliant Medical Group in Milford, Massachusetts, and is board certified in pediatrics and lifestyle medicine. She has an academic appointment of Associate Professor of Pediatrics at University of Massachusetts Memorial Medical School. She completed her undergraduate degree at Cornell University with a bachelor's in nutritional science with honors and her MD at the Stony Brook School of Medicine. She did her residency in pediatrics at Hasbro Children's Hospital, Brown University. She has been involved in the Massachusetts Medical Society and now is a vice chair for 2 committees on mental health and substance use, and also the Committee on Oral Health. Current research interests include the role of lifestyle medicine in prevention and treatment of adolescent depression. She co-chairs the Pediatric and Adolescent Lifestyle Medicine Interest Group at the American College of Lifestyle Medicine. She recently co-authored the Teen Lifestyle Medicine Handbook, The Power of Healthy Living. A couple of housekeeping items. This session will be recorded for educational purposes. By participation on the Zoom platform today, you are consenting to the recording. This recorded presentation will be available on our AAP Alaska chapter website in a couple of days. Please remember to mute your mic during the presentation and enter your questions in the chat box for our Q&A segment at the end of the presentation. And with that, take it away, Dr. Dalal.
Great. Thank you for inviting me here. I'm excited to be here today to speak about lifestyle medicine and its applicability to pediatrics. One second. I have no financial disclosures or conflict of interest with the material in this presentation. Our objectives are as follows: summarize key pillars in lifestyle medicine and review some of them as they apply to school-age children, identify ways to encourage these lifestyle changes, and review how to develop SMART goals and an individualized lifestyle medicine action plan. So what is lifestyle medicine? Lifestyle medicine is the use of evidence-based lifestyle approaches to prevent, reverse, and treat chronic disease. Lifestyle medicine has been shown to be highly effective and addresses the root causes of disease. In lifestyle medicine models, we can take time with patients to address habits and promote a lifestyle that reduces disease incidence. Lifestyle interventions can include individual interventions, group interventions, such as the Complete Health Improvement Program or the Diabetes Prevention Program, or community interventions. These lifestyle therapeutic approaches are the basis of lifestyle medicine, and through this patient-centered practice, better outcomes and lower cost result. These approaches do not have to be used in isolation, but should be a component of all treatment plans. These ideas, although not all new, really helped me re-embrace medicine. About 5 years ago, when I felt burnt out, I needed to find a way to re-energize my practice. And through lifestyle medicine and by being involved with ACLM, or the American College of Lifestyle Medicine, I found my village, a group of individuals in the US and around the world who wanted to embrace prevention and embrace patient-physician relationships and find ways to empower patients and families to make healthy choices. As this quote says, "We have long known what behaviors promote health and prevent disease." Lifestyle medicine embodies this idea of true healthcare. Rather than pills and procedures, the focus is on the lifestyle choices we make every day. The chronic disease epidemic is rampant. The content in this slide is from the CDC, noting 6 in 10 adults have a chronic disease and 4 in 10 have 2 or more. According to the World Health Organization, 80% of heart disease, stroke, and type 2 diabetes, and 40% of cancer could be prevented primarily with improvements to diet and lifestyle. The sick care system built to service sick people is breaking the bank. We need to change the approach to medicine with something different, something simple, intrinsic, but not always easy to implement. The solvency of the United States is truly at stake, and we know one of the answers is to reduce demand for care delivery, to offer solutions at a better cost, and to focus more on prevention to encourage health and to reduce chronic disease. All of this is possible through lifestyle medicine, and there is data to back this approach. Lifestyle medicine specifically addresses 6 pillars of health: healthy eating, physical activity, sleep, stress management, substance use cessation, and social connections. Now, just take a moment and think about these pillars and think about not only how it applies to your patients' lives, but how you prioritize them in your own life. Do you feel that you have been able to adopt a lifestyle that encourages the healthy eating, abundant physical activity, adequate sleep, limited stress, substance use cessation, and healthy and adequate social connections? The beauty of lifestyle medicine is just that. It helps us learn how to help our patients and families change behaviors, and in that process, we can reevaluate our own habits and move towards increasing our own wellness. If we can view health through the lens of lifestyle medicine, we can focus in on habits which patients and families can adopt or change with a bit of guidance. And lifestyle interventions can help empower patients and families to manage their own health, sometimes without the need for continuous and often costly future healthcare interventions. All of the 6 pillars of lifestyle medicine apply to every range of patients, but we have a real opportunity to change the trajectory of lives when these lifestyle changes can be implemented in childhood and persist. In fact, research at the Ornish Centers, headed by Dean Ornish, MD, suggests that lifestyle choices could turn on or off more than 500 genes. There's a wonderful opportunity for us to influence our own health and the health of future generations. Through spending some time with families and speaking directly to children, we can help increase their own intrinsic motivation to develop these healthy habits. We can help impart some knowledge using cash principles. This is a concept often taught in business schools to help students develop new habits, and it's based on the understanding that it is not enough to have knowledge, but we must shift attitude, develop skills, and form new habits to see changes in individuals, which leads to success. This process can also be applied to our health, allowing cash to make us successful in our health changes with our patients. This all begins with us understanding the pillars of lifestyle medicine, and because of our limited time together, I'll focus more heavily on a few of these pillars as outlined in the objectives. The first pillar of wellness is to eat well, specifically promotion of a whole food, plant-based or plant-predominant diet. Poor diet is the leading cause of chronic disease and disability. Over the last century, processed food has infiltrated our diets, and whole plant food makes up only about 6% of what we eat. Ancestral diets were not so. Sure, hunters went out and gathered meats and we were eating them, but in fact, a greater portion of the diet, some say up to 70%, was vegetables. Current vegetable intakes fall short of recommendations, and we can see in these pictorial representations from the National Health and Nutrition Examination Survey, where the blue bar represents the range of recommended intake for vegetables here, and the orange dot indicates current intakes of vegetables. At all ranges, vegetable consumption is lower than recommended. This figure specific to fruit intake shows that average intake of fruits is below recommendations for almost all age sex groups. Children ages 1 to 8 differ from the rest of the population in that they do meet recommended intakes for total fruit. We see this already. Parents often relish in the fact that their young kids eat lots of fruit, but we can now see we specifically need to encourage this continuation past age 8 and encourage this consumption in the years beyond. Inherent in pediatric anticipatory guidance are recommendations to eat more fruits and veggies, etc., but perhaps adding some new language may help. And the suggested language lifestyle medicine practitioners will use is eat whole food, plant-based, or whole food, plant predominant. Why? Because habits get ingrained early and are difficult to change as we get older, and also because changes in our heart start early. Data from the Bogalusa Heart Study shows atherosclerotic change in arteries starts in childhood as young as age 2. Chronic disease, such as high blood pressure, high cholesterol, kidney disease, heart disease, can be prevented or helped or even treated with a plant-based diet. In this pictorial diagram on the left, from work by Dr. Esselstyn, we show insufficient coronary artery blood flow in an individual. And in the lower diagram, we show that after just 3 weeks of a plant-based nutritional intervention, normal blood flow is restored. In fact, multiple trials show the benefits of a whole food plant-based diet, including the Adventist Health Study, Lifestyle Heart Trial, and those others that are listed on this slide. And there's also significant number of studies that have been reviewed that show the benefits of a plant-based diet. It has also become easier to convince others to consider a more plant-based diet for environmental reasons, knowing that a plant-based diet can help protect our environmental resources and feed more individuals. An easy motto coined by Michael Pollan that follows these recommendations is eat food, not too much, mostly plants. These recommendations already exist to some degree. Many of us use MyPlate, developed by the USDA. It too emphasizes fruits and vegetables, whole grains, and proteins. In fact, eating whole food plant-based is the basis of most diets, whether you're eating low-fat, vegan, vegetarian, Mediterranean, but seeing all these different diet recommendations can get very confusing. So we present this new phrase to give clarity: whole food, plant-based. Whole food describes foods in their natural state, which are not processed. That means whole, unrefined, or minimally refined ingredients. And plant-based means foods that can come from plants and don't contain animal ingredients such as meat, milk, eggs. Foods from plants also include nuts, seeds, whole grains, and beans. For those who may have a hard time with adopting a plant-based diet, it may mean changing the proportion of your diet, which is from a plant source. So instead of being fully plant-based, perhaps you can be plant predominant. And it doesn't always mean that you'll never eat meat, but that you're more likely to include more plants in your diet. Encouraging whole food plant-based in a visual format may make it easy for families to understand. This is the ACLM Whole Food Plant-Based Pediatric Plate Visualization, and the recommendations make clear the idea to fill half of your plate with vegetables and fruits, a quarter with whole grains, a quarter with plant proteins. And it talks about using herbs and spices as flavor enhancers, which may entice naive eaters to try new foods. Instead of animal dairy, we add water as the primary beverage. And this is actually very similar to the new Canadian food plate. Specifically, it's important to point out the importance of eating a rainbow of color and the nutritional benefits from this. Many families may think about broccoli, corn, peas, potatoes being staple vegetables, and even being able to make specific suggestions by naming other varieties and fruits and veggies present in your localities, and exposing them to new and easier methods of food preparation can be helpful. Let them know that canned and frozen fruits and veggies are acceptable choices. In fact, frozen fruits, because they are flash frozen at ideal times and may not have the breakdown of nutrients as they are left on grocery store shelves, may provide even more nutrients than some fresh fruit. Discussing preparation of these vegetables may be helpful, i.e., like how do you ripen or use an avocado? You might discuss that ripening in it involves time, but to speed that up, an avocado can be placed in a paper bag with a banana that will ripen it faster, usually overnight. In order to eat it, we have to cut it open and take out the pit and slice it. And adding lemon or lime juice to pieces can keep them from darkening. Eating it on whole grain or in a salad may be delicious, and adding seasonings can make it spicy. Giving such ideas sometimes will help change the experience for those who have never eaten these types of vegetables or fruits. Even the idea of plant-based proteins, which include many vegetables, legumes, and nuts, may be new for some people. Parents have an obsession with getting enough protein into their kids, so it's important to discuss how plant-based proteins can provide adequate protein. This can include beans such as kidney beans, black beans, lentils, and all kinds of nuts and seeds. Choosing whole grains may not be an automatic choice for families with children, so suggesting alternate whole grains may help, like quinoa, couscous, or whole grain tortillas. And sometimes we need to assist them in telling them how to prepare these grains. I often ask what type of equipment they have at home, which helps guide how to encourage whole grain preparation. For example, many families now have an Instapot, and so I'll talk to them about how to make quinoa, 1 cup of quinoa, 1 cup of water, veggie broth, and 1 minute high pressure, and then that natural release, which allows quinoa to be prepared. Many families are really focused on eating in one way, and often because they've grown up that way. So asking people to make small shifts, such as from white rice to brown rice or white bread to whole grain bread, may pose an early challenge, but knowing that whole grains break down differently in the body and are more nutritious may encourage them to eat them. And when children start eating this way early, these habits continue through their lifetime. The 2015 to 2020 dietary guidelines for Americans encourage families to shift the way they eat. So choosing nutrient-dense snacks versus high-calorie snacks or fruits instead of fruit juice or fruit products with added sugars can be suggestions to make. And small changes in food choices over time can make a big difference. Promoting cooking at home may be needed. Children and families may need to know how to do this, but particularly if they don't do it already. It takes knowledge and skills to be able to cook. And I recently became a culinary coach to help children and adolescents do this. This coursework is offered through the Institute of Lifestyle Medicine at Harvard. We, of course, also need to encourage healthy beverages without sugar and make water clean, safe, and easy to access in homes, schools, and communities. There's a fun app called Plant Nanny, which encourages water consumption for kids. Other water-based apps also exist. Just a brief note on dairy, and this is the topic for a much longer discussion, but cow's milk dairy may not be needed. There are studies which show dairy can contribute to some health problems, and calcium and vitamin D can be attained from other supplemented sources like plant-based milks, such as soy beverages. Vitamin D can be attained from 15 minutes of sunlight. Foods like kale, broccoli, green leafy vegetables, beans, fortified soy products all have calcium. And then nuts have calcium, almonds having the greatest amount. One thing to point out is that if you are on a fully plant-based diet without any animal products, vitamin B12 will need to be supplemented. And vitamin B12 is made by microorganisms and isn't produced by plants, so it's important to supplement. So let's review some evidence-based tips to making a healthy food home, some of which I know you heard about recently. Modeling good behavior. As we know from anticipatory guidance, we already give, parents modeling good behavior encourages healthy eating. Prioritizing family meals. Eating family dinners is associated with healthful dietary eating patterns, but these meals could be any time of the day. Introducing, exposing, and re-exposing kids to new foods makes a difference. And as we know, it can take up anywhere from 5 to 15 times for kids to increase acceptance of the food. This can be done by having food available. So after school, having healthy snacks ready to eat, hold family tasting events, or have kids get involved in food shopping and preparation. The next thing is we have to believe that eating healthy encourages happiness. Historically, comfort foods with high sugar and salt content have been associated with happiness and comfort, but foods don't have an intrinsic comfort quality. And so parents and children have to shift their attitude about which foods will make their kids feel happy. I also want to focus on the last 3 points here because another lifestyle-focused intervention in kids is encouraging mindful eating. We want to encourage moderation, help kids learn what makes them full, and minimize distractions by practicing mindful eating. Chaotic mealtimes negatively affect everyone, including parents. Making mealtimes more enjoyable and less stressed is important. Decreasing distractions like media, which allows parents to pay attention to the kids' emotions and model good responses to hunger cues, is also important. So encourage the practice of mindful eating. This pictorial handout from Johns Hopkins explains the process well. So first, allow kids to prepare to eat. This can be an opportunity to create a more pleasant eating environment, a nice tablecloth, some candles, a clean table. Help them breathe and relax and get ready to eat. The idea of practicing thankfulness for what is about to be eaten is a good way to express gratitude and appreciate the food, and it may allow one to relax as you prepare. Help them notice what's on that plate, the taste, the texture, the smell, maybe the touch. Coach them to chew slowly and thoroughly, enjoying the foods bite by bite. And when eating, it takes about 20 minutes for our brains to feel full, as we know. Let kids know that once they feel full, it's okay to stop eating. If a child can't finish the plate, put it away for later. Make eating a separate activity away from screens or school or work, since it can be an active enjoyment to nourish our bodies. And we want them to feel that way, that it is an active enjoyment, an active self-care. Encourage time for children and families to participate in that during your clinic visits. Some resources to encourage whole food plant-based eating. There are many resources available. This is one example. It's the Physicians Committee for Responsible Medicine book, Nutrition for Kids, which is free to download. The book is filled with recipes, suggestions for healthy snacks, sample menus, and much more. Plantrition Project has great information on how and why to encourage plant-based eating for kids and families, and this is also free to download. Parents can also read more about this through books such as Intuitive Eating, which is by Dr. Yemi Cazorla Lancaster, or How Not to Die by Dr. Michael Greger. Perhaps you can collect a set of recipes in your clinic which families can share or you can distribute. Through our interest group, we developed a scavenger hunt for kids to complete in the grocery store. Community or school-based resources may also need to be developed. Resources can include where to find fruits and vegetables, farmers markets, community gardens, and how to prepare these foods. So consider educational materials at food banks or at those farmers markets. Changing eating habits and improving them over time is a golden opportunity for pediatricians, and we must encourage this change in every way possible, for we know that the food you eat can be either the safest and most powerful form of medicine or the slowest form of poison. The second lifestyle intervention is to focus on physical activity. Physical activity and movement can improve every facet of health, both physical and mental health problems. And by encouraging this and facilitating this, we are setting children and families on a lifelong path of health. We already encourage physical activity in our well visit, but there is evidence that physical activity can help in all aspects of health, including headaches, stomach aches, depression, anxiety. There have been many peer-reviewed publications by many in this field, and Dr. Jan Ratty, a psychiatrist from Cambridge, has some great literature about this. Specific recommendations are given by the physical activity guidelines for Americans, which includes recommending 60 minutes of activity with at least 3 days a week of moderate to vigorous physical activity, which should include muscle and bone strengthening exercises at least 3 days a week. AAP also released recommendations earlier this year stating that free play and organized sports are good options for activity, also noting that physical activity encourages socialization when we're able to. The reality is that recommending any type of movement rather than being sedentary provides long-term health benefits. And so we must encourage physical activity with every interaction and review individual interests, discuss barriers, offer very specific suggestions, talk about simple play at a playground as a muscle strengthening activity and how jump roping can strengthen the muscles and is a very good aerobic activity. Perhaps you can consider in-office demonstrations with weights or resistance bands or videos or apps, and then setting goals for the child and family may help them meet them for the upcoming years. Some clinicians even choose to write a play or movement prescription, and this can also be done just like we prescribe medications. This is an example of one developed by the team of Rise Vermont and adopted by ACLM. Our next lifestyle medicine pillar is sleep. Adequate sleep improves all facets of mental and physical health, including attention, behavior, learning, memory, and emotional regulation. Poor sleep leads to health problems, which may be linked to increases in inflammatory markers due to sleep deprivation. A brief review of sleep science may be helpful for children and families. Discuss melatonin as a hormone secreted by the brain, or if they want specifics, the pineal gland, which increases throughout the night and is affected by light and dark and temperature. It is important to add that parents can help encourage adequate secretion of melatonin without using external supplementation. In fact, sleep specialists who are part of ACLM discourage routine use of melatonin at night, as bioavailability of current products on the market is unpredictable, and because natural does not always mean safe for long-term use. Parents and children may benefit from knowing that melatonin is made and released in a clear pattern called our circadian rhythm. This internal clock resets every 24 hours to 25 hours, and this influences sleep and wake cycles. or it may help them to know that our body temperature changes throughout sleep. So knowledge is important, but how we ask about sleep also is important. For example, when we see kids having trouble, we can ask, what makes sleep important for you? How do you think you can sleep better? How do you think you will feel if you sleep better? What are you doing now to help your sleep? What could you do differently? And with that information, we can suggest improvements in sleep habits.
Already know, our residents are still.
Sleep duration is important to discuss, and the National Sleep Foundation recommends 9 to 12 hours of sleep for kids ages 6 to 13. We can recommend physical activity and play because this can help improve sleep. Studies show exposure to light in the morning and in the daytime can improve nighttime sleep. We can also recommend reducing caffeine intake throughout the day and let kids and parents know caffeine is in many kids' products, flavored dairy, energy drinks, chocolate-containing foods like cookies and candy, and soft drinks. And we can see that consumption of these products increases by age, and with caffeine having a half-life of 6 to 12 hours, it can absolutely affect sleep. And then as we know, another recommendation is to have a consistent sleep time. Studies show a change of more than 1 hour from bedtime or wake time can affect the circadian rhythm. And so it's important to keep sleep times and wake times similar. Having a bedtime routine can also help. And encouraging a calming activity like reading with an actual book or practicing mindfulness before sleep can help ensure a good nighttime sleep. Studies show that melatonin secretion can be delayed up to 90 minutes after room light exposure. So parents and children must be encouraged to turn off screens at least 1 to 1.5 hours before sleep. Keeping rooms quiet and dark and starting with screen-free rooms early on can help. The blue lights from screen can disrupt sleep onset and duration, so the goal should be to keep screens out of the bedroom and have dimmer lighting throughout the end of the evening. And just like the Playscription, we developed a Sleepscription with ACLM to help families track sleep and choose goals to help sleep. That brings us to the next important lifestyle medicine pillar, stress management and building resilience. Stress can be good or bad. Good stress helps us to do better, and bad stress keeps us from doing well. Helping families build strength and be resilient takes time, but the key is to understand that even the effects of toxic stress can be mitigated through building resilience. And doing enjoyable activities is helpful as a way to manage stress. Learning how to breathe well can be practiced in the office and then at home. When seeing an anxious child, we could say, would you help me feel a little more calm today? Let's just take a brief moment to feel calm. Take a deep breath in through your nose and out through your mouth. Ready? All of you can practice with me too. Take a deep breath in through your nose and a longer breath out through your mouth. Maybe you do it a couple more times and notice how you feel. I like to use the American Girl movie McKenna's technique of breathing. Blue skies in, gray skies out. Perhaps you like progressive relaxation and you want to take a moment to practice this with your patients. Breathe in and scrunch your face tight, 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 as tight as you can, and hold for 5 to 10 seconds, and then relax. Breathe in and out. Or inhale and make a big arm muscle. Hold for 5 to 10 seconds, and exhale and relax. Breathe in and make your stomach muscles tight, 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 tight. And then breathe out. And notice how you feel. And ask them to notice how they feel when you do that with them in their offices. Just like these, many other stress relieving practices can be encouraged. Another one that patients and parents seem to like is keeping a gratitude journal where they write a brief thanks to reflect on a nightly basis maybe, or during the day at some point, to really appreciate those things that are around them. Helping families know how to build resilience can help in many ways. And this can be done in lots of different ways. Learning how to think positive is helpful. And this may be just encouraging thinking on the bright side or finding the positive in any given perceived negative situation. Setting goals with realistic expectations can help. Practicing acceptance of their own strengths and weaknesses, both parent and child, may help. And families should allow kids to problem solve and work and find solutions rather than doing it for them. Helping build resilience takes time and effort and may require additional professional assistance at times. Learning to be mindful is something that can be taught. Mindfulness is the process of being aware and non-judgmental of a situation, emotion, or circumstance and observing it, or allowing a pause before any immediate reaction. This is helpful to learn to regulate emotions and understand the thoughts and be aware of feelings. One way to practice this is by taking a walk. Point out new things that you see. How many times have we walked or driven down a road and not noticed any of the new things on the way till months after they appear? Kids are the same. Lives get busy and they stop paying attention to small things within them and around them. We want to encourage these practices daily so that when challenges arise, children and families use those skills. Presenting strategies in your office can encourage stress management. This can include 5-minute in-office guided imagery, an emotion board or paper plate emotion mask, identifying emotions with words as they arise or mirroring, the mindful breathing. Sesame Street and Communities is a good site to go to learn about emotions. The Galaxy jar or stress ball may be helpful, and you can make a stress ball with the use of your non-latex gloves, or show them how to make a Galaxy jar where sparkles settle in water to help them understand how to make their emotions settle. ACLM has developed a worksheet about this, but so have many other organizations. We also have information on how to develop a calm kit for kids. Another idea we often discuss is how to develop a calm corner instead of a timeout corner and help design that. Obviously for older kids, just a plain calm corner can be helpful, where they can have a soft rug or mat, a beanbag chair, or other plush options for sitting or lying down, and with some favorite books or stuffed animals or quiet toys or whatever helps them feel calm. Perhaps suggesting an app may help. The tools are abundant. We just need to encourage stress management and mindfulness at home, in our clinic visits, in schools, and other community venues. We also need to encourage social connections, the 5th pillar, and acknowledge the significant impact of loneliness on physical and mental health. So what are ways we can encourage that? It can be formal, such as joining clubs or sports, or it can be informal by ensuring opportunities are present daily to connect. For example, ensuring you have a meal together during the day or taking a walk together can allow opportunities to discuss concerns or just improve relationships. Finding activities families can enjoy with their child allows time to share their feelings and know they are valued. Encourage screen-free, non-task-oriented, or free time to do this daily, even if just for a few minutes. The last pillar of lifestyle medicine is substance use cessation, which is so important across the lifespan. And I won't be able to get into the details of this, but just want to restate the obvious in that we have great opportunities to encourage substance use cessation early in families' lives and throughout the school age years, just by asking, screening routinely, and referring early. Learning how to make these lifestyle interventions to lead a healthier life means encouraging existing habits to continue and new habits to form. And being able to have time with patients and families to do this is important to allow behavior change to be explored. One way to help children and families through this is by developing some SMART goals. And these are goals which are specific, measurable, achievable, realistic, and timely. So perhaps the parent can make a SMART goal. I will help Lucy eat more fruit. Maybe you give them a time. By when? By the end of May. How? By having cut fruit available after school every day. Or maybe you speak to the child and they want to make a goal that we want to try one new vegetable. And how are they going to do that? By having one at snack every day. And maybe you try to give them a time frame. So goal setting tips, before setting a goal, determine the motivation for change. And as a goal is set, write down the goal for you and the family so it can be tracked. And after setting the goal, review those barriers and facilitators so we can really determine what's keeping them from meeting those goals. You might also consider developing an action plan where you choose a couple goals for the family to work on together for the year, since sometimes you will only see families once a year. So consider a family-based intervention plan where we create SMART goals that include not just individual tasks, but also family tasks, which may need to take place to achieve the goal. These encourage child and family problem solving and cooperation, and it often helps families feel they leave with concrete advice during the visit, something they can hang up or keep with them. And just a side note, all the tools I mentioned, which were developed through ACLM, are available if desired and can be sent out after this talk. When we talk about interventions and how to make sure lifestyle interventions and how to ensure we discuss them within the office, we can ask more lifestyle questions, and you may be able to adapt your current EPIC or electronic medical record to include questions which discuss these particular pillars. There are screening tools that are available and being developed right now. One includes the whole child assessment. We want to assess readiness for change, develop these goals, and as discussed before, review barriers and facilitators to change. We want to have some of these tools in our office. We want to use simple language and suggest tips, maybe from other families, and send some information home to review with them. And set up a follow-up visit or maybe a community referral if needed to a program that encourages things like physical activity. It may be easy to see how these lifestyle medicine approaches can be encouraged in a well visit, but also using these pillars as the focus of problem-based visits may allow new measures to be implemented. Here are some examples. One problem-based visit is for kids with constipation or functional abdominal pain. We can suggest healthier eating, not only what to eat, but how to eat well, gather a diet history, offer reduction in milk as a management option, offer elimination of milk and replacing it with plant-based milks, which can sometimes help since cow-based milks have A1 beta casein, which in some studies is associated with slow transit and gastrointestinal inflammation. Talk about increasing fruits and vegetables and whole grains and how they can do this. And again, discuss plant-based fiber increase through unprocessed foods such as flaxseed powder and oatmeal. Then we can talk about physical activity since the colon responds to exercise and people who exercise more are less likely to have constipation depending on the type they have. The next thing might be to discuss stress and the effects on the bowel. High levels of stress can cause or aggravate gastrointestinal symptoms, and perhaps relaxing or breathing slowly, for example, use of bubbles in young kids or breathing techniques in older kids can help the gut function better and allow better bowel movements as a treatment for their constipation or abdominal pain. For high BMI, ensuring the parents and families want to discuss their weight is helpful. Seek permission. Ask them, is this something they wish to discuss further? And usually they say yes. Then reviewing their habits and seeing what they want to change is helpful. We are used to talking about healthy eating and increased physical activity. We can also encourage whole food, plant-based eating. Discuss what a healthy plate should look like. Maybe have a younger child draw what their plate currently looks like and how they could change it. Encourage that water intake throughout the day or fruit sweetened water. Suggest specific tips, again, with permission. One that I like to share is that eating right before sleep may be unhealthy. And so making it a habit not to eat in the bedroom or before bed may be good. You know, having dinner and a brief snack right afterwards and then water till morning is another way to discourage the previous habit. When discussing physical activity in this context, offer to explore ideas with them, help them know what type of movement, that any type of movement is a start, and explore what type of movements are interesting to them. This is where SMART goal development gives them something to work towards. And let them know how sleep alters metabolism and getting enough sleep is important. Kids who tend to stay up later tend to eat more. This is actually called night eating syndrome, and it's caused by dysregulation of body clocks that impact appetite, sleep-wake times, and overall energy levels. The lifestyle medicine approach works well to discuss obesity since all the pillars are interrelated and serve to be a basis of prevention and management of obesity. And the beauty of using the framework of lifestyle medicine in discussions from the beginning is I can now go back when problems arise and use the same lifestyle medicine framework to help manage the problems. Families are now used to it, and we just have to re-envision the next steps. When we review ADHD, part of that discussion should include lifestyle interventions. Healthy eating makes a difference. A study of over 14,000 preschoolers in China showed that eating processed foods and snack dietary patterns were significantly and positively correlated with ADHD symptoms. In school-age kids, a study published in 2017 in pediatrics showed lower adherence to a Mediterranean diet was associated with ADHD diagnosis. These don't prove causality, but indicate a role for dietary discussions in ADHD, not as the only form of treatment, but as part of the ADHD management plan. And physical activity should be encouraged in all these environments, both at home and school with ADHD. Activity breaks can be written into 504 plans since we know studies show movement helps attention. A study in pediatrics in 2015 by Dr. Hosa in kids between kindergarten and second grade showed that as little as half hour a day of moderate to vigorous exercise had a positive measurable impact on their focus and mood. And on a larger scale, we can advocate for recess at every age level to help with attention and mood. Next, we can talk about sleep, as we know sleep affects daytime attention and focus. And stress management and helping children and families be mindful has promised to help ADHD symptoms as kids learn to be still and foster the formation of new brain connection. Increasing healthy social connections can also help kids with self-control by engaging in more activities, being involved with less screen time, and perhaps engaging in more goal-oriented activities. In the slightly older child, we might be diagnosing depression. Healthy eating, a whole food, plant-based diet is known to make a difference. Studies show processed foods are more likely to be associated with poor mood, and we know what a child can eat can influence their mood, or what a child eats can influence their mood. In fact, there is a whole field of medicine emerging called nutritional psychiatry, which focuses on this. Increased physical activity also has been shown to help with mood. One study by Babiak et al. Showed each 50-minute increment in increase in exercise per week was associated with a 50% decrease in the odds of being classified as depressed. Many other studies show that any form of physical activity can make a difference. Even the act of moving versus sitting can help. Sleep, as we know, has also been shown to improve mood symptoms, and there are specific aspects of sleep more associated with depression, such as the time to go from full wakefulness to sleep. Stress management, as discussed before, can help with depression, and so being able to help mood through meditation, relaxation, imagery, these are all techniques which can be taught. Substance use cessation has a bidirectional relationship with depression, and being able to refer children early can prevent worsening depression. And lastly, again, encouraging those social connections can prevent loneliness, improving mood, and reducing depression. So this is a subject of current research at our clinic, although with adolescents, and we hope to be able to integrate specific lifestyle interventions for mood-related visits. Lifestyle intervention should be considered as part of the prevention, management, and treatment in all aspects of health. And through this presentation, many of the resources which have been presented have been created by multiple groups around the country, all dedicated to improving children's health. The reality is no one person or group can make the difference we need to see, but by envisioning health from all different perspectives, we can continue to improve our kids and their families' future health prospects. I hope you will take this opportunity not only to bring a new perspective to your practice, but also to your own lives. We spend so much time to take care of others, we often forget to take care of our own mental and physical health. The pillars of lifestyle medicine are really meant for you and those who you care for, whether it's your patients, your families, or yourself. Thank you for taking the time to be here, and look forward to networking with you through our work at ACLM or individually, and I'm happy to answer any questions.
Thank you, Dr. Dalal, for that great presentation. I especially appreciated all the nutritional information, refresher tidbits, especially. I didn't know about the banana avocado in the paper bag trick. So thank you for that. All right, check in the chat box here. There is a request to share, if you could share the slides with us. I know we're recording it, but I guess there's some other useful information I think people might find helpful. Would you, if you're willing to do that, please do share that with us. And then I see that Dr. Rosier from Ketchikan has a comment question for you. Please feel free to unmute yourself.
Hi, my name is Elisa Rocher. I'm a pediatrician in Ketchikan. Thank you for that presentation. It was really positive and bright. One thing that I'm dealing with here is families are kind of on the brink of disaster. Our city, a big income source is tourism, and we don't have any cruise ships coming. So families are literally like trying desperately to make ends meet. And already, like prior to the pandemic, I kind of felt guilty telling families about recommendations of fruits and vegetables because fruits and vegetables are so expensive here, like prohibitively expensive, like $3 for an apple kind of expensive because they're all shipped out from the lower 48. And now, as I was listening to your presentation, I was like, I'm not even broaching any of these subjects because I can feel like the tension of just like survival in my appointments. And, you know, families are just, the normal family life is just really disrupted at this point in the pandemic. And I just wonder if you could speak to that or kind of give any insight into that kind of situation. Thank you.
Yeah, I mean, I agree. I mean, in this time, it's a bit more difficult to perhaps do our routine anticipatory guidance that we do in pediatrics. I think part of this is that there just are a lot of stressors, and we may not be able to address each of these pillars that we're talking about. But even the very fact that we're talking about that stress with them and empathizing with them about that stress, and even the simple suggestions sometimes that maybe, you know, just going back into a routine, because one thing we found here is a lot of people during the pandemic were out of routines. They were doing things very differently, and that perhaps getting back into those routines can make a big difference. So I agree that there will be times when we are not going to be able to discuss these things. And I also have a large Ecuadorian population within my own clinic who's, you know, low resource, and it can be hard for them to access those fruits and vegetables, both because, you know, in where they live, they can't necessarily find them. And so that's when we do talk about being able to use some of the canned vegetables and fruits, and our local pantries. We've been able to talk to them to ensure that they're able to encourage that. If we have excess from some of our farmers markets, we make sure that our food stamps are accepted there. And so there may be other options for them to be able to incorporate these fruits and veggies and other healthier dietary plans. But absolutely, I think you have to meet them where they are. And I think that that is hopefully one thing that lifestyle medicine really promotes, and that's that really understanding, you know, where they are, accepting permission to have those further discussions. And if they're not ready, we can step back. That's okay. You know, we can discuss whatever they are ready to discuss in that moment, and then let them know that we're there when they want to make some changes, if they want to. I mean, again, some of this may be just accepting them where they are, and then they come to you saying that maybe I want to make this type of change, or maybe I want to do this in the future, if you just accept them where they are at any given time.
Thank you. That was an awesome presentation.
Thank you.
Hi, my name's Kevin Collins. Thank you for the presentation. It was a great talk. I had a question. With when you see patients, are you like incorporating all of this into a well-child check? Are you being referred patients for kind of lifestyle medicine coaching? And then if so, I'm thinking about just the volume of information you could really dig into. Like, how much time do you allot for this?
Yeah, that's a great question. I love that question because, you know, ideally I would love an hour with all my patients, but I think we all realize that that is impossible to have. So the information that I currently give is something that I do tidbits during my physical exams. And so basically I have a plan of what I want to discuss during those infant years, school age years, adolescent years. And over time, we've started to incorporate that within our electronic medical record. So we ensure we're discussing at least some aspect of those specific pillars that I discussed. So we don't have a separate lifestyle medicine clinic that we refer to, or a separate lifestyle medicine coach, although because we are moving towards more behavioral health integration in our counselors are actually really interested in this topic. They are starting to do some of these discussions when they're referred, particularly for mood issues. So in that way our goal is to have a health promotion clinic where specifically people can come in and have these longer conversations, because you're absolutely right. During our brief clinical visits that we get, there's only so much we're going to be able to do. But what I found in the few years that I've been practicing this is that being able to set even just 1 or 2 2 goals is just something that they can work towards over that year. And then the following year, I can come back and, talk about it with them. And hopefully they've made some very, very small changes moving in that direction of increased health. And hopefully parents appreciate that. I mean, some adolescents sometimes find it difficult in the beginning, but oftentimes they'll come back and say, yeah, we're ready to move forward and want to do this for themselves. And so I think that it can be done within the context of regular visits, but in smaller tidbits over time.
Thank you.
Any other questions out there? I see that we have a few school nurses joining us for the presentation today, so we welcome any comments, questions from you.
This is Michelle Lawfer. Can I ask a quick question?
Of course.
I'm wondering, I saw, I'm looking for some of the handouts that you sort of showed, the resources, because I think those would be really helpful. And is there any centralized, I think it kind of maybe went too fast, I couldn't find them all. Is there a good place you recommend we go for handouts about some of the things you were talking about?
Yeah, I mean, so we're trying to create a central repository at the lifestyle medicine sites. And so right now, if you're a member, you're able to download a significant number of tools that have been created through the Lifestyle Medicine Intervention Group. And then if you're not an actual ACLM member, you still can download significant amounts of, or I'd say a good number of tools also. They're a little bit more adult oriented. And so the pediatric ones, I had mentioned that I would be happy to send out some of the ones that we had created for the school age population. And then, for example, the ACLM plate that you saw in the very beginning, that is available to download by anyone who wants to go in. And that has the plate, and on the back of it has tips for how you can encourage a whole food plant-based diet. There are a lot of resources that are available, and right now we're hoping to make them more widely available and accessible for others to use. But right now it's mostly through these presentations and just being able to send them one-on-one.
Yeah, because I find that, I don't know if other people find this, but so much of what I do in, general pediatric practice is this stuff. I mean, it seems like it's the most important thing that we do, because it's the rare kid who actually has a medical need that requires medication or referral, but they have all these needs, all of them. Mm-hmm. And it's just the more resources I have to hand people to take home and to talk off of, it's just super helpful. So I really, really appreciated this talk and this topic today. And any way to get those things you were talking about, those handouts, I would love that.
Yeah, and for those who are on the call and are interested in some of this material in general, over time we're developing more and more resources. And the nice thing about being a member of ACLM and the pediatric interest group is that we have access to a sort of a marketing team who can put together information we give them. Again, we're researching the material, we're making sure it's evidence-based, and it's a team of, right now we have about 100 pediatric providers who are within the MIG, and a subset of them are working on the specific clinical tools. So right now we have some of the ones that I showed you today. We also have an entire toolkit that focuses on lifestyle interventions for adolescent depression. And that's the focus of some of my research. And so those are a couple that are available. And then in the fall of this year, there's a conference that's occurring that will have Dr. Yemi Kazarula-Lancaster, who I had mentioned earlier, and Dr. Cherie Chu talking about sort of lifestyle medicine interventions in infancy. And after that, there will also be an infant toolkit, which will also have those types types of resources. And so that may be, if you're interested in considering joining and helping us out and developing some of these, the nice thing has been that we've been able to develop them, have them look very, very nice because we have a marketing team that works with us and be able to distribute them to people around us.
Thank you so much.
And hi, Michelle, I'm Colette. So I am, I'm also a part of ACLM. I'm not on the Peds Interest Group Committee, but I can definitely be a resource since I'm here in Alaska and kind of work with Michelle to get some information to everyone.
That sounds great, Colette. Yeah, I'm happy to send you anything that people request. And my email is on the screen right now. So feel free to email me also if you have any questions.
Another quick question, if we have a second, and it's to you, but also kind of generally out to everybody else in the audience. I mean, ideally, we'd be seeing, I'm thinking of like BMI patients or patients I get referred for hypercholesterolemia that are also obese, and I'll see them in a couple of months when we're rechecking labs and we discuss all the lifestyle management. For general pediatricians out there, like you said, you may be seeing patients once a year. Ideally, we're seeing them, we'd be seeing them more often because it's those multiple points of contact and reinforcement that can really help. Has anybody tried to do that and had pushback from insurance companies? Like if you're trying to say, I'm going to see you back in a month and we're going to see how you did over the last month, I could see insurance companies saying, no way, we're not paying for that. Do you or anybody else in the audience have experience with that? Thanks.
I could definitely speak to that, and then hopefully somebody else in the audience will. So I definitely have not had any pushback yet in being able to do that, and I agree with you. So for people who are interested in working on their weight and their BMI, if their families are interested, then I will see them back every 3 months, actually. If they're very, very motivated, sometimes I'll see them back in 6 weeks, and I sort of have a plan of how to implement these or how to discuss these lifestyle interventions with them so that they're able to practice it. And the most difficulty they typically have is incorporating all the dietary measures, that we want to have them move towards. So that's definitely one thing. And then, for example, with depression, I'm already seeing them back because, sometimes they're on SSRIs or other medications. And so being able to incorporate these lifestyle measures at each of those visits or at each of the ADHD visits has been very easy to do. And so, yeah, I have not had any pushback.
Good to hear. Thank you.
And I'm not sure if, because I work at South Central Foundation, so I haven't gotten personal pushback from visits that I have had to formulate plans. And I've been doing a lot of SMART goals with the kiddos and with, I have a range of diagnoses that I can bill for. So hypercholesterolemia, elevated LFTs, elevated blood pressure, elevated BMI. And so I have kids come back, 6 weeks, 3 months, typically, to review SMART goals. And I haven't personally gotten any pushback from where I am.
That's great to hear. Thank you.
Hey, this is Susanna Olness. At ACP, we offer a once a month follow-up, and I don't know very much about whether or not we're having any issues with our insurance, but with getting reimbursed rather, but I have not had anybody come to me to say that we weren't. So I think it's actually been fine.
What kind of stuff are you doing in your 1 month follow-up? If I had an ACP patient that I'm seeing, should I be referring them back to you as far as saying, hey, you need to talk with Dr. Olness or Dr. Abernathy about this monthly, like specific monthly thing?
Yeah, so basically, I think we're all saying, if you're interested in making lifestyle changes, we're interested in supporting you with goal setting. And honestly, one of the biggest problems is when kiddos get really excited, the whole family wants to make a change. They go home and they start doing that change, but then something comes up and that they just basically kind of fall off the wagon, so to speak, right? So They,
like me.
so we suggest come on back in so we can keep working on setting goals, but also just to remind yourselves, let's keep on, keep on. I mean, once you make the change of eating 5 to 9 fruits and vegetables or whatever, it's easy to forget to do it after a couple of months, and then you slide back into your old habits. So I've had some really, really great successes. The other thing that is not really lifestyle changes or functional medicine directly, but I'll start kids on metformin who are simply obese, and to prevent developing, and I work with the endocrinologists around this, so that we can start improving their hemoglobin A1C somewhat, but mostly it's really helpful for reducing their appetite and then changing their diet. And a lot of times kids will just automatically go off once they've started to realize that they don't need to eat constantly all day. And they're eating some of the healthier foods. They start to realize, oh, this makes me feel better. So that's kind of a nice little thing a tool you can use as well.
Thanks for those comments, Dr. Olness. And I think we are at the end of our time, unfortunately, but Dr. Dalal, thank you very much again for sharing all that wonderful information with us. And please feel free to share any other resources or links with me or Dr. Rial, and we will post those on our website so that others can utilize those. Anyway, everyone have a great rest of your Tuesday. And we are, this will actually be our last Grand Rounds, correct, Dale? Before our summer break, our traditional summer Grand Rounds break. And we will plan to resume after the Labor Day holiday, and hopefully, fingers crossed, in person, as the conference rooms hopefully will be opening up to larger audiences. So thanks again. And if our Grand Rounds schedulers could stay on, just stay on the same link. Thank you. Otherwise, have a great day, everyone.
Bye, thank you.